diabetes mellitus. Now what happens in diabetes is that you get a high serum glucose, obviously. And the high serum glucose results in non-enzymatic glycosylation of the vascular basement membrane. Now when you stick sugar on the basement membrane without the use of enzyme, that's called non-enzymatic glycosylation. Of course, when that happens to the vascular basement membrane, that's going to result in the basement membrane becoming leaky. And so what's going to happen is that protein will leak into the wall of the blood vessel, creating something called hyaline arteriolosclerosis. And we talked about hyaline arteriolosclerosis in the vascular section. And recall there, I told you that hyaline arteriolosclerosis occurs with both hypertension, in particular benign hypertension, and diabetes. Now, when you get hyaline arteriolosclerosis, the problem is that you get thickening of the blood vessel wall with this protein-like material, which then results in a decrease in the caliber of the lumen. Now, it's important to note that in diabetes, what actually happens is that if this is the afferent arteriole and here is the efferent arteriole, you get preferential hyaline arteriolosclerosis in the efferent arteriole. Now, that's going to reduce the caliber of the lumen and creating an increased pressure in the glomerulus, right? If you tighten this, there's going to be more back pressure here in the glomerulus. That increased pressure in the glomerulus is going to create hyperfiltration, which is going to initially begin as microalbuminuria, but eventually you'll get sclerosis of the mesangium of the glomerulus, and as you get sclerosis of the mesangium of the glomerulus, it'll progress to nephrotic syndrome. Now, one of the important things to recognize concerning this pathogenesis is that if you give patients ACE inhibitors, you can actually slow the progression of the hyperfiltration injury. And the reason is because angiotensin II also squeezes down here. And so now that additional squeezing down is only going to create additional hyperfiltration injury. So if you can block angiotensin II, you'll decrease some of that pressure at the efferent arteriole, which will then decrease the hyperfiltration injury. So let's read together what we say in the text. In diabetes, you get high serum glucose that leads to non-enzymatic glycosylation of the vascular basement membrane. By the way, that's the very first change that occurs in the kidney. Non-enzymatic glycosylation of the vascular basement membrane. Sometimes examiners will ask you what's the first change. This then results in hyaline arteriolosclerosis. Of course, the efferent arteriole is preferentially affected, leading to a high glomerular filtration pressure. The high filtration pressure results in microalbuminuria. This eventually progresses to nephrotic syndrome. The hallmark of nephrotic syndrome would be that you would see sclerosis of the mesangium, and that sclerosis results in these classic nodules called Kimmel-Steele-Wilson nodules. And as I've mentioned, ACE inhibitors would slow the progression of hyperfiltration-induced damage. So here's a picture of the glomerulus. Here's the round glomerulus here. And notice that in the mesangium, you've got this dense sclerosis. And of course, these are Kimmel-Steele-Wilson nodules. Here's a perfect one right here. Very high yield, as this is pathognomonic for diabetes. The last disorder that can create nephrotic syndrome would be systemic amyloidosis. Remember that when patients have systemic amyloidosis, the kidney is the most commonly involved organ. I told you that when we talked about amyloid. The amyloid will deposit in the mesangium, and that will result in a nephrotic syndrome. Of course, a biopsy would show Congo red staining with apple-green birefringence under polarized light. Now, basically, in summary, we've done the nephrotic syndromes, but just remember there are 6 nephrotic syndromes and study them in pairs. Minimal change disease, FSGS, membranous, membranoproliferative, and then diabetes and amyloid. And so in each of these, again, you have some common themes. And I think if you understand nephrotic syndrome in this way, you'll be very strong in this topic. That concludes our discussion of nephrotic syndrome.